So I think it is 10:25, and that's our scheduled start time. So we will go ahead and dig in. So welcome everyone, and thank you for joining us for our breakout session this morning. My name is Danielle Lauder, and I'm the program director for the Northeast Telehealth Resource Center, covering the New England states, New York, and the northern part of Jersey. Just a couple of logistics for folks who may not have joined us in the previous week's sessions. We will take about an hour for this presentation. We'll have an open Q&A with our speakers, Leah and Terry Ann, at the end of this session. So we'll be able to kind of open things up. I do ask that folks use the Q&A function within the EventMobi app. It's a little bit easier for us to track there. However, if folks do enter in the chat, I'll copy and paste them over there into the app. But that also allows us to upvote, if you recall, or if you're unfamiliar with the app. You can upvote questions that you're really interested in hearing the answers to. That way, if we get a long list of questions, we can make sure that we sort of prioritize them and get to those right away at the beginning of the Q&A. So I think other than that, you know, we're fairly informal with the breakout sessions. We're so excited to hear from our two speakers, this innovative model. So without further ado, I'm going to keep the introductions very brief per our tradition, so that we can give the majority of our time here to our wonderful speakers. So first off, we have Terry Ann Thompson, who is Senior Associate at IBIS Reproductive Health, with much experience in domestic and global settings. She leads research, the research portfolio at IBIS, and focused on the impact of policies such as the Hyde Amendment and innovative healthcare models such as telemedicine. Very excited to have her here with us today. And then a person that we've had an opportunity to work with for a number of years and has shared their experience with their innovative model is Leah Copeland. She's the program director at Maine Family Planning. She currently oversees their telehealth services and strategizing to find innovative ways to increase access to sexual and reproductive health, including all of those services that fall under family planning services. So these wonderful ladies have agreed to share their time and expertise with us here today, and they're going to be talking about client and provider support for telehealth, specific to provision of reproductive health care. And without further ado, I'm going to go ahead and turn it over to Terry. And Sean, if you would like to please share Terry Ann's slide deck, that would be excellent.
Thank you so much, Danielle. I appreciate that. Good morning, everyone, and thank you so much for joining us. We're really excited to share on this topic and to share about some of the collaborative work that has been done between Maine Family Planning and IBIS Reproductive Health. So next slide, please. Great. So now that we're started, I will go ahead and tell you that our learning objectives in very brief format is that we'd like to increase your awareness of telehealth models for sexual and reproductive health services and identify the ways in which these models increase access and center patient care. Next slide. To get us started, I hope to try to set the context for why telehealth has risen to the forefront as a model of care for sexual and reproductive health. But first, I'd like to tell you a little bit about my organization and why we do this work. Next slide. So IBIS Reproductive Health is a nonprofit research organization that drives change through bold, rigorous research and principled partnerships that advance sexual and reproductive autonomy, choices, and health worldwide. One of our three strategies is actually to conduct research which could transform access to abortion and contraception through service delivery and technology innovations. As such, for more than a decade, we've been evaluating services that leverage technology to provide sexual and reproductive health services and information. I'm incredibly proud to have been in partnership with Maine Family Planning for several years now. In the United States, sexual and reproductive health services are inaccessible for a number of reasons. Next slide. First, we see limited availability of providers. Research from the organization Power to Decide on contraceptive access in the US estimates that 19 million women of reproductive age were in need of publicly funded contraception, but lacked reasonable access in their country or in their county, rather, to a health center that offered the full range of contraceptive methods. For these women, accessing a preferred birth control method will take more effort and resources. In 2019, the domestic gag rule was enacted, which is a set of restrictive regulations that prohibits, among other things, referrals for abortion care. Post-enactment, the Guttmacher Institute actually estimated that roughly 1 in every 4 Title X service sites left the network, reducing the network's capacity to provide women with contraceptive services by at least 46%. That translates to about 1.6 million women with fewer choices to receive contraceptive care. Next slide. Second, we see that restrictions, such as abortion restrictions, can increase distance to care. In 2019, about 58% of US women of reproductive age lived in states that were considered hostile to abortion rights. And in the midst of the pandemic, we've seen legislators introduce bills to restrict abortion access during this time. And while some judges have stepped in to block some of these attempts, others have moved forward. Restrictions exact a heavy toll on individuals seeking an abortion, forcing many to have to travel out of state or large distances to get the care they seek. In 27 cities, people must travel over 100 miles to reach the nearest abortion providing facility. Next slide. Third, we see that inadequate practical supports, such as transportation, childcare, and limited clinic hours, can actually impact receipt of certain sexual and reproductive health services. In the US in 2018, about 1 in 16 infants was born to a woman receiving late or no prenatal care. And these practical supports that I've listed on this slide have been actually associated with accessing prenatal care inconsistently or not at all. Next slide. Finally, the stigma associated with some sexual and reproductive health services, such as HIV, actually prevent some individuals from receiving testing and treatment. So when you think about HIV, which typically has labs conducted every 90 days or so, and individuals usually have to see a provider every 3 to 4 months, the frequency of these appointments can actually be very burdensome, even if the individual lives in a location where an HIV specialist is easily accessible. And if they live in an area where there are fears of stigma from their community, then that access will actually be diminished. Next slide. So in an effort to address some of these barriers to access, we've seen clinics, hospitals, and health insurance plans rely more on telehealth to reach patients who otherwise would not be able to see a healthcare provider. In the cases outlined, telehealth has increased access to contraception, to abortion, to prenatal care, and to STI and HIV testing and care by eliminating barriers to receiving in-person care and by accommodating the patient's needs, whether that be childcare or comfort. Next slide. So during the pandemic, we have seen the need for a shift in healthcare delivery, and that's because of restrictions to non-urgent healthcare, as well as physical distancing guidelines. Telehealth has actually helped to provide as well as sustain access to reproductive healthcare services during this time. Next slide. We have observed a surge in interest as well as use of telehealth for sexual and reproductive health services. So we've seen clinics providing telehealth medication abortions having a 30% increase in service provision. And we've also seen sort of an elevation of telehealth models for contraception and HIV. Next slide. We have also seen a shift to broad coverage of and equal payment for telehealth services during the pandemic. This shift has presented an opportunity for more people to engage with telehealth services without concern for costs on the patient side or payment on the side of the provider. Next slide. But the shifts have not all been good. At least one state has introduced a bill to ban telehealth provision of medication abortion. Telehealth restrictions for medication abortion not only make it difficult to access abortion care, but places providers and patients at risk of contracting or spreading COVID-19 by mandating unnecessary in-person contact. In the next few slides, we intend to describe a telehealth model for sexual and reproductive health that's being used in Maine. Then we'll highlight some of the available evidence for sexual and reproductive health telehealth models. And finally, we'll talk through how the telehealth models actually satisfy the Institute of Medicine's definition for patient-centered care. And finally, we'll open up the space to talk through some considerations for implementing sexual and reproductive health telehealth models. So with that, I'll pass it on to Leah.
Next slide. Thank you so much, Terry Ann. It is really great to be here and an honor to present with Terry Ann, who, again, we've worked closely for several years now. And my slides are showing up a little differently. So if you could get to the slide that has the map of Maine, it might be one or two ahead. That would be great. So a little background. First of all, I'm a nurse midwife. I am also the program director at Maine Family Planning, and Maine Family Planning has been around for over 40 years. We were, until last summer, the sole grantee for the state of Maine for Title X, and as Terry Ann mentioned, with the change in federal rules around funding, we actually discontinued our relationship with the Title X granting program last summer. And that was really due to some of the regulations around what we could say as far as evidence-based practice, as well as making meaningful referrals for our patients. So we ended that relationship. However, we continue to subcontract with over 20 various subcontracting organizations, including federally qualified health centers, school-based health centers, Planned Parenthood clinics, and some other community health centers, and serve over 22,000 Mainers each year. We have a full range of services, including sexual and reproductive health care, pregnancy testing, options counseling, pre-pregnancy counseling, referrals, contraception, STI testing and treatment, HIV testing, PrEP for prevention. We have an open door program, which is our transgender healthcare program. We also provide abortion services in one of our main clinics in Augusta, up to 14 weeks for aspiration abortions, and then we do medication abortions. And we participate in the Genuity Health Project study, which allows the mailing of medications for medication abortion. We also have a program called the Reproductive Empowerment Program, which I'm going to talk a little bit about later. We have a very robust education department and train educators throughout the entire state on how to teach comprehensive sexual health education in Maine middle and high school students. And we also do advocacy work in the state and federal level. So we have quite a big footprint in the state in the sexual and reproductive health field. Next slide, please. So back in 2014, we started, we really launched into the telehealth world. And again, this is where the Resource Center and Danielle have been really helpful to Maine Family Planning. They were one of our first people that we reached out to really get things going. But back in 2014, we started doing a medication abortion via telehealth program. And this was really to serve two of the most rural counties in the state, and states where folks had to travel sometimes 300 miles just to get the services for abortion. Next slide, please. So this was a model that probably many of you are familiar with. It was a typical clinic-to-clinic, what we call a clinic-to-clinic model, where we had a patient in one clinic and a provider in another clinic. So in this case, we had a patient who would travel to their local clinic, which could be in rural Maine or any of our 18 clinics, and they would get the services that they needed there from the nurse practitioner. And then when it was time to see the physician, they would use a telehealth model, and the physicians who were based in our Augusta clinic could see that patient. Can you just hit next on the slide? There you go, thank you. Once we had that model established and we sort of had the infrastructure of having the technology in all of these places, we began to expand what clinic to clinic could do, including sometimes if we just had a really busy clinic, we could move a patient to a telehealth visit, and that patient could see a nurse practitioner in another clinic. We also began using it for when we just had provider call-outs or somebody was sick, and rather than canceling a full day of clinic, we could have those patients, if able, be seen at another clinic through this clinic-to-clinic model. We also used it for training. So if a provider needed more training, they could see a patient in their clinic and they could have observation with somebody in another clinic. And our transgender health services specifically, as we expanded to rural Maine, that allowed the nurse practitioners who were experts in that care to actually see those patients while they were in physical space with another nurse practitioner in a different clinic. Next slide, please. So the next model that we added to our telehealth program was the Reproductive Empowerment Project, which basically leveraged the infrastructure and the expertise we had in this clinic-to-clinic model, and we brought medical assistants into community settings, many that didn't have easy access to sexual and reproductive health services, and that included domestic violence shelters, needle exchanges, recovery centers for folks with substance use disorder, and various other places where the community members felt that it was really hard to sometimes have clients access our services. Next part of the slide, please. Thank you. So we work with several organizations around the state, and we continue to expand. And basically, a medical assistant goes into these settings and is available for any clients who want to. They can then telehealth back to one of our providers in a clinic. So the medical assistant's with the client, and then they are able to also provide them with services right there. So the medical assistants carry with them birth control pills to dispense, blood pressure cuffs. They can do basic lab work, all of that. And it just allows us to bring sexual and reproductive health into these settings if patients desire. Next slide, please. So then a couple years ago, again, taking what we had for telehealth, we decided to expand to what people are very familiar with now, which is direct-to-consumer or direct-to-patient telehealth model. And this was also a very modest program at the time. We basically offered fairly straightforward, simple services such as birth control starts, uncomplicated UTIs, visits that really involved counseling or informed consent processes but didn't involve any physical assessment. And we launched this a couple years ago with very modest success, really only had a handful of folks taking us up on that. And next part of the slide, please. Next slide, yes. And one thing that is to know is that we really were just at the precipice of trying to market these services. So in the beginning of March, I was at a conference at the NFR conference, the National Family Planning and Reproductive Health Association conference, and one of the main points of our presentation was how to market these services, because we felt like we had this great offerings, but nobody actually was taking advantage of it. And it's hard to believe that was the beginning of March, and things have, of course, changed dramatically. So at that time, telehealth was really a very small slice of what we were providing. And again, doing just some modest offerings at that point. Next slide, please. Oh, this is just about the teleabortion study. You can go ahead to the next slide. So as you all know, the world has changed since then. Now telehealth is the bulk of what we are doing, and it really forced us to look into how we could expand. So for example, prior to this, we were fairly conservative in some of our guidelines. For example, around contraception, we did progestin-only methods because we wanted to make sure that we had a blood pressure for every patient who wanted contraception. And then as we dug deeper and looked into the CDC guidelines, and I have them right here, in instances in which blood pressure cannot be measured by a provider, blood pressure measured in other settings can be reported by the woman to her provider. So what we've started doing is asking folks, have you had a blood pressure in the past year with your doctor, your dentist, maybe you're at your grandmother's house and she's got a blood pressure cuff. And you'd be surprised how many people can report a normal blood pressure within the past 6 months to a year when you ask that question. We also have folks who said, well, there's a machine right at the grocery store. Can I use that? And we say, absolutely. Next time you're in the grocery store, go ahead, write down the date, write down your blood pressure, and that is adequate. We also really looked at risk benefit, and for healthy young folks with no other mitigating issues, the risk of low dose birth control is so minimal that providing them with a few months of contraception outweighs the potential risks. We also added any kind of consenting, any kind of education, any kind of pre-visit work we could do to the visit. So for IUD consenting, education, for our depot shots, we can do all of the education. They just come in and basically get a depot shot. We also, with our transgender healthcare, expanded dramatically with that as well. And we basically moved all of our follow-ups to telehealth. Again, looking at what kinds of visits did people need, and if they just needed lab work, could they just go in and get the lab work, but have every other aspect of that visit done remotely. And then one of our biggest changes was with our abortion services. We initiated a no-test medication abortion protocol. And again, we looked at the guidelines out there by our organizations ACOG and NAV. And next slide, please. I guess this is really hard to read, but as ACOG said, you know, that an ultrasound should not be a barrier to abortion care. Next slide. And this is just a protocol that was developed very early in the pandemic to make sure that people could access care. So this is all to say that at this point, we are really trying to, next slide, figure out how to move forward with our telehealth service. This is the million-dollar question, right? Will patients want to continue with the telehealth visits, or will they prefer to return to in-person visits when able? And this is something that we're looking into right now to see, you know, and anecdotally, and I can say this having seen many patients over the past few months. By far, patients do not seem anxious about telehealth. They seem very comfortable with it. They don't seem to have some of the anxieties that we might suspect. They seamlessly move into this telehealth model of services. So we really are trying to figure out what will the future look like. We're going to start in next month with some text surveys that will go out with all of our telehealth appointments, and they'll be very simple types of questions about satisfaction, but also kind of get a sense, if you could have had this visit in person, would you have preferred that? And we also are starting what we're calling a virtual patient advisory board. We're hoping to gather some folks from these tech surveys who would want to help us to create this new telehealth service. And really what we've kind of realized is with our 18 clinic model, moving to over half of our services via telehealth, we've really kind of retrofitted, we've kind of gone backwards and said, how do we take this 18 clinic model and stuff telehealth into it everywhere? Whereas if we were building something fresh from the ground up in terms of scheduling, in terms of equipment, everything, what would we do if we knew we were going to operate sexual and reproductive health services for the state of Maine, and 50% of it was going to be telehealth? How would that look different than what we're using right now? So we're really starting to do a lot, you know, kind of taking a pause from just the absolute mad speed we were in when COVID started and just everybody was kind of flat out changing everything. And now we're saying, okay, let's take a breath. What would we build that would meet our patients' needs and meet, you know, this new demand? The other thing I'll just highlight is that there is a effort right now to expand broadband coverage in Maine, which Maine Family Planning has taken a stand on. It is one of our ballot questions that we really feel like that this is an essential piece to assuring that the most vulnerable people in our state do have access to services. And as we're seeing specifically with COVID cases in Maine, that it is disproportionately being where we have the highest rate of disproportionate cases in Black and Brown communities in Maine. And we think of folks who are maybe most vulnerable because of the type of healthcare work they're doing, and access that they have to care as being so limited. And we feel like it is essential that we really advocate and lobby to make sure that as telehealth expands, that everybody in our state has equal access to it. So we are working on that, working closely on that ballot question right now. All right, so I will pass it back to Terry Ann. Thank you.
Thanks so much, Leah, for giving us that wonderful overview. Next slide. In this next section, I hope to give you a brief overview of some other SRH, so sexual and reproductive health telehealth provision models, as well as some of the current evidence on their use. I will dive a bit deeper into the case of medication abortion, just so that it gives me a chance to highlight some of the collaborative work that Maine Family Planning and IBIS Reproductive Health have done. Next slide. So multiple services in the United States actually offer the option to obtain birth control via telehealth through either a mobile app or a website. And Lemonade is one such online birth control provider. To receive services, a client actually completes a health questionnaire, which a medical provider then reviews. And if the client is living in a state that requires a video conference, the provider will actually conduct one with the client. Otherwise, the medical provider will write a prescription for the client if medically appropriate. In terms of research, a review of 9 different telehealth contraception providers, which includes Lemonade, actually found that the health questionnaires used by these services were evidence-based and adequately screened for the majority of health conditions that are contraindicated by birth control. Next slide. Some other evidence on telehealth for contraception models are first a randomized control trial that found that women who received an app with contraceptive information, in addition to standard care, actually had increased contraceptive knowledge, increased interest in some long-acting contraceptive methods such as the implant, and an increase in short-term use of any effective contraceptive method. Secondly, there are findings from a set of injectable contraceptive studies, and they found that participants who received daily interactive text message reminders were almost 4 times more likely to continue use of injectables or a more effective method at post-intervention, so about 20 months post the evaluation. Next slide. At the Mayo Clinic in Rochester, Minnesota, there's a telehealth program for prenatal care called OB-NESS. And this program gives clients the opportunity to communicate with their healthcare team through text messages, as well as provides them an online community monitored by a nurse where they can discuss their pregnancy experience. This program actually combines traditional care visits with remote visits and monitoring. And with the remote visit, the patient actually corresponds with the obstetrics nurse via a phone or messaging service. Very quickly, a randomized control trial of patients receiving prenatal care in the traditional format versus telehealth found that telehealth patients actually had higher satisfaction with care, lower pregnancy stress, and very similar clinical outcomes. Next slide. So very quickly, some other evidence on telehealth for prenatal care models. One quick study that has been done on the effectiveness of mobile prenatal care apps to facilitate a reduced in-person visit for low-risk pregnancies found that the use of this mobile app was actually associated with reduced in-person visits and that there was no reduction in patient or provider satisfaction. There's also a study that investigated the effectiveness of web-based prenatal care, and they looked at pregnancy-related stress as well as general self-efficacy, and found that those women who were in the e-health cohort actually reported significantly lower pregnancy stress and significantly higher self-efficacy. And last but not least, there was an observational study that compared the satisfaction of obstetric patients who received about 1/3 of their prenatal visits via virtual care versus those who received all of the care via face-to-face visits. And what they found is that satisfaction was actually higher in the virtual care cohort. And more significantly, women who already had children were more likely to select the virtual care model. Next slide. So Lemonade, the online platform that I mentioned earlier around contraception, also provides a synchronous model of care for urinary tract infection treatment. Each Lemonade client actually completes a video or a mobile consultation with a provider who, based on the client's reported symptoms and medical history, actually determines if it's appropriate to prescribe antibiotics. Next slide. While evaluations of the use of telehealth for UTIs in the US are sparse, there are only 2, the results from these studies are actually aligned with the results that we see outside of the United States. Very briefly, an evaluation at the Mayo Clinic that compared UTI patient outcomes from in-person visits, nurse phone visits, and telehealth appointments found no differences in clinical outcomes or the rate of antibiotic prescribing across the 3 groups. Similarly, an evaluation of antibiotic prescribing, follow-up rates, and clinical outcomes between face-to-face visits at a retail clinic, nurse phone protocol encounters, and e-visits for the assessment and management of UTIs saw no difference. And in fact, what they learned is that UTI Patients who received care via telehealth actually described it as the more convenient option. Next slide. Finally, we look to HIV and STI care. Here I present two models. The first, Checkmate, is a mobile app that gives clients the options of in-lab or at-home testing. With an at-home appointment, the client actually receives a testing kit through the mail, completes all the test requirements, and then mails the kit back to Checkmate. For the in-lab tests, Checkmate provides, the provider sends a test order to a lab of the client's choosing, and the client goes to the lab to complete the testing. Checkmate also offers counseling for positive test results, and in some states will actually prescribe treatment. There are also several online telehealth companies that offer HIV prevention services via telehealth, and they do this in the form of PrEP and PEP prescriptions. One service is called Plush Care. It offers necessary lab tests that PrEP clients must complete every 90 days. Through this service, clients have an at-home synchronous virtual meeting with a doctor, and it's followed by lab work. And once the labs are complete, if they're eligible, the client will actually receive a 90-day prescription of PrEP. A quick study done in Iowa on PrEP initiation found that the telehealth system actually effectively delivered care in small and urban rural settings. Small, urban, and rural settings, sorry. Next slide. So other evidence on telehealth for HIV and STI models, very quickly, we see from a qualitative study of young adults that were diagnosed with chlamydia and chose a telehealth platform to assess their results as well as manage their medications, that these participants chose the model because it allowed them to obtain treatment rapidly, conveniently, and privately. They also described that the online consultation was prompt, discreet, and easy to complete. A systematic review of digital innovations for HIV and STIs found that all digital innovations in their final sample were actually highly acceptable and feasible. mHealth-based innovations, internet-based innovations, and combined innovations were all found to significantly improve antiretroviral therapy adherence as well as clinic attendance rates. And finally, researchers conducted a cluster randomized evaluation to determine the impact of availability of HIV telehealth programs on documented viral suppression in Veterans Administration's clinics. And they found that the availability of telehealth programs actually led to small improvements in viral suppression. Next slide. So now I'd like to talk about abortion care. And in the context of abortion care, telehealth services have been used for counseling and assessment, to acquire abortion medications, to guide patients through the abortion process, as well as to assess whether the abortion was completed or if there were other needs. Leah described earlier two telehealth models that they've offered at their clinic. One she described as the in-clinic. I'm going to call that the site-to-site, and the other the direct-to-consumer or the direct-to-patient model. Next slide. So in 2017, IBIS Reproductive Health implemented an evaluation of the site-to-site telehealth for medication abortion model that was offered at Maine. The evaluation design aimed to answer questions about the safety, acceptability, feasibility, and accessibility of the telehealth model for medication abortion. And our design actually collected information from patients through surveys and in-depth interviews, from providers through in-depth interviews, and from the clinics themselves through an extraction of service delivery statistics. Next slide. Very quickly, we surveyed about 97 patients, that's telehealth and in-person medication abortion patients, to understand their perspectives and experience with telehealth. And we did in-depth interviews with all the providers in Maine to understand their experience and levels of satisfaction with telehealth services. Next slide. The interview questions for the providers actually tried to assess their opinions of the telehealth service as well as their perspectives on the service's impact on patients. All of them provided very positive impact about telehealth using words like innovative, necessary, cutting edge, revolutionary when describing the service. The majority of them said that telehealth actually improved access to medication abortion because the implementation of telehealth actually allowed patients who would otherwise have to travel long distances to receive care to not have to do that. They also remarked that the experience seemed largely similar for the patient. getting the service via telehealth as those getting the service via in-person medication abortion. So as one provider put it, the actual experience or how long they spend with a doctor or any of that doesn't actually change between the in-person and telehealth visit. Next slide. So in terms of the patients, the survey asked patients to report their level of satisfaction with various aspects of their care, including their conversation with a doctor, their overall abortion experience, etc. And about 98% of them reported being somewhat satisfied or very satisfied with the abortion services that they received. The majority said that what they liked best about the care they received is the compassionate and non-judgmental staff. They also liked the ease and the speed of the appointment process. Next slide. And about 88% of those patients also reported no preference for the doctor's location. So here very quickly, we see the patient saying, I don't care where she was, but I think that having a conversation with someone in person versus over like video chat isn't very different. I think in this day and age, when people have video conversations often, it doesn't make much of a difference, especially for a video chat where it mostly gives relaying information. I didn't see it as anything different or weird. Next slide. So very quickly, we have done several evaluations of site-to-site telehealth for medication abortion models, and across these evaluations, we found that the service is safe and effective, with 99% of patients having a successful abortion. We found that patients and providers are highly satisfied with this model of care. We found that it increases access to those in remote locations. And finally, we did a qualitative study with 19 telehealth leaders of telemedicine and telehealth organizations in the US, and found that most felt that telehealth was appropriate or well suited for medication abortion. On this slide, I've put a picture of a toolkit that IBIS recently pulled together that synthesizes evidence from these efforts. Next slide. So in brief, if you walk away with nothing from this section, I want you to walk away knowing that the use of telehealth in sexual and reproductive health is growing. There are several models available for use, and while evidence is still being generated, many of these models have actually been found to be safe, effective, and acceptable. Next slide. So I mentioned earlier that the Institute of Medicine actually cares a lot about patient-centered care, and they describe patient-centered care as care that is respectful of and responsive to individual patient preferences, needs, and values. Next slide. And what we know is that the implementation of patient-centered care is important because it has been shown to contribute to improved outcomes for patients, better use of resources, decreased costs, and increased satisfaction with care. Multiple studies actually show that patient-centered care improves patient satisfaction, quality of care, and health outcomes while reducing healthcare costs and disparities in healthcare. Next slide. So when we think about whether telehealth centers sexual and reproductive health patients, we don't need to look any further than the evidence generated for medication abortion in the US. And here on this slide, I've highlighted what we've seen under these 5 domains for accessibility, availability, accommodation, affordability, and acceptability. So with accessibility, I've already mentioned that it expands access to more locations. For availability, we found that there's an increase in appointment availability. For accommodations, we've learned from the direct-to-patient model evaluations that it accommodates childcare, as well as helps patients avoid harassment from protesters, as well as stigma attached going to the service. For affordability, because it lessens travel costs, it actually lessens the overall cost of the abortion. And finally, for acceptability, I've already mentioned that it's highly satisfactory to patients and providers. Next slide. One other factor I want to mention very quickly is that the patient-provider relationship is one of the single most important factors in quality of care. And I hope I've already established with our evaluation for Maine that a large percentage of the patients that we surveyed actually were satisfied. About 81% were actually satisfied with a conversation with a doctor, and 88% said they would not have preferred to be in the same room as the doctor for their appointment. Next slide. So now we can quickly amend our takeaways to say that telehealth models for sexual and reproductive health are not only growing in use, but they're also patient-centered. Next slide. Before I go, I just want to mention very quickly that there's still room to expand access to telehealth services for sexual and reproductive health care, and there are 4 areas where we have to do some work. The first is around coverage, because that is not consistent across insurers or states. The second is state regulations. There are still states that actually don't allow for telephone consultations or online questionnaires. So it necessitates a video call for telehealth services, which is incredibly limiting for those with unreliable internet or cell phone service. The third is that there are still states, there are actually 17 states that have laws that explicitly ban the use of telehealth to deliver medication abortion. And finally, while we are seeing some work around trying to increase funding for telehealth programs, the under-resourced community health centers may not be able to apply for this funding. So we're seeing uneven or unequal implementation across states. So now I'll pass it over to Leah to spend the last 3 or so minutes just discussing other considerations for implementations of sexual and reproductive health telehealth models. I think 5 minutes before we open up for questions. Thank you.
Thank you, Terry Ann. Next slide, please. So when thinking about some considerations for adding sexual and reproductive health services, and this is, whether or not you do many services, or if you're a family practice and just regularly do some birth control, I think there's a couple things that we've certainly learned along the way. The first thing that we did originally was make a matrix of visit types. So we looked at, first of all, what others were offering locally and nationally. And Terry Ann mentioned some of the services out there, Lemonade, there's New RX. I'm sure many of you have seen those come through on Facebook ads and all of that. So look at what other things are being offered. One thing I think we learned actually last year at the NETRIC conference, which was really helpful to us, was to know that even with these big national platforms, people tend to be more comfortable using a telehealth service if there is an associated bricks and mortar facility that they're familiar with. So even though it may seem hard to compete with some of these big national platforms, what we do offer is that we do have, again, 18 clinics around the state. So while maybe you can get your birth control really quickly with an app, if that birth control is troublesome, or you want to move to a long-acting reversible contraceptive like an IUD or an implant, you can come to any of our clinics and do so. So we try to kind of leverage that advantage that we have. So looking at what else is offered, also then we did a matrix of like what we actually did in our visits. What were the components? What actually required touching a patient as opposed to just seeing a patient, as opposed to being sent for a lab for tests. And then finally, what visits required very minimal in-person contact. So maybe they did require, again, an injection for depot, but that was just one piece of it. The rest could be done via telehealth. Or in the case of our estrogen-based contraceptives, were there other options for them to get a blood pressure? So we kind of made this matrix to figure out these different categories of telehealth types visits. And then we were more easily able to move anything that didn't require that in-person visit as an offering for telehealth. We still offer folks the opportunity to come in if they want, but we really streamline that telehealth if they prefer. Terry Ann also mentioned the payment and reimbursement issue, which is huge, especially in the abortion world right now. So we have a lot of advantages in Maine that allows us to do the services that we do in a way that still allows us to get reimbursed. That is not the case everywhere. So really understanding what is involved in the reimbursement and what is required. And while many things have been waived for the pandemic in terms of what is needed, we also want to set up a system that will continue even if some of those loosening of regulations are reversed. Thirdly, and I'm sure everyone has already been doing this, but looking at your technological infrastructure to see what you can support, staff training, that is obviously key. And again, this is where we're doing kind of a look back now to see how could we build this differently if we knew what our demand would be. And finally, demand. Again, this was a really big issue for us prior to March, was trying to get the word out and marketing and all that. And of course, now we don't need to do any marketing about our telehealth services because that is what we are offering and what people want. And but again, that patient access piece, specifically in some of the more rural areas, to assure that folks will have access to broadband. And one thing we did notice is prior to COVID, you know, we had patients who would sometimes see us from a library. Students had a computer from school, perhaps, that they used. But now that many libraries are closed or have been closed, students didn't always have the same access to their computers. So even though everybody was kind of home, they just all of a sudden didn't have that reliable access that they might have before. So it even highlights more how we need more coverage for internet services in our state. All right, so I think we're about ready to do our questions and answers.
Excellent. Thank you so much to both Terry Ann and Leah. That was phenomenal. And you can see that they are very passionate about this focus area and have really, that's pretty amazing. I love seeing the data from the 5% utilization of telehealth services, Leah, before, you know, pre-COVID, and then 60%. You guys were really able to quickly ramp up the services and make them accessible very quickly and effectively. So thank you both so very much for sharing. So everybody who's, we don't actually have any questions in the Q&A, and we have a small enough group that we're able to unmute folks if you would like to ask a question verbally, if you prefer that, or you can absolutely type into the chat or the Q&A, and we will have Terry Ann and Leah answer your questions. Everybody's quiet this morning. Maybe the second cup of coffee, or the third, if you're like me. I thought it was really interesting too to hear you talk about, and it always is, and for different use cases, the comfort and satisfaction with among both patients and providers is just quite amazing, because obviously the quality are clearly very important factors to consider. So we really appreciated you going in depth, both of you, around those areas. Let's see, we do have a question. Asmat says, Terry and Leah, thank you. Are you partnering with telehealth vendors to build your next generation system as you refine your requirements?
So that's a great question. We currently are using a platform called InTouch, which is now part of Teladoc. We started with them a long time ago when actually their previous company was called TrueClinic. So we started, it was a small clinic that was then bought out by InTouch, which has now been subsumed by Teladoc. So we've kind of been going along with them. What I've been actually really trying to do is figure out what are the essential components of the telehealth platform that we need, because what I've seen is that many platforms have maybe 2 of the 3 things I want, but it's hard to find something that kind of does everything, and there is some uniqueness to our services. So I think that is something I would definitely recommend, is like what features are most important. The EHR that we use just launched its own in-platform telehealth option, and we've been trialing that as well. So right now we're kind of using 2 at once to see. And but again, each one sort of has its own little quirks. And for example, the share screen feature is just one thing that I never thought of that when we started up with choosing our telehealth platform. I didn't think of that as really a necessary feature, but now that we're doing more and more specifically of these no-test medication abortions where the informed consent piece can sometimes take 45 minutes or even longer because there's so much information that we're trying to convey. Having a share screen is really nice to be able to put that consent or those instructions right up so that the patient can see them simultaneously. And so some platforms offer that, some don't. And again, it wasn't something I had thought of at the beginning, but now in COVID times, I feel like that's an essential piece. When you're just going through a lot of information at once, it's really helpful to have those visual cues. So yeah, we're still in process deciding which vendors we'll move forward with.
Awesome. Terry Ann, did you want to add something there?
I wanted to ask Leah if she could expand a little on the privacy and whether you find that patients are feeling like the consultation is pretty private.
Yeah, that's a great question. So it is interesting. I mean, recently I had a mom and she's like, I have 4 kids at home, but she had just gotten in her minivan and drove to the parking lot at the, Walgreens down the street. And that's where she felt like she could have privacy. But what she said to me is, I couldn't have come into a clinic. Like that wouldn't have been an option for her. Again, she had 4 young children. So leaving them for as long as it would take to drive to a clinic, to do a long appointment, and all of that wasn't an option. But the fact that she could kind of be perched right nearby made that helpful. I did a visit yesterday with someone who had her new puppy on her lap the whole time, and I feel like it was just a really nice way for us to connect. I don't want to discount the ways that it can be very exposing for some folks, depending on what environment, what their home looks like, what the sounds are. And, I know folks who are doing teaching remotely notice this a lot, and who's able to put a camera on, who chooses not to put a camera on, and what that feels like and looks like to have somebody invading your space that way. In my experience, I feel like for the most part, it has felt like a benefit in that people feel really comfortable sharing pets, or somebody's sometimes nursing a baby and having a visit at the same time, and those things that allow everybody kind of to be who they are, where they are. So we do have once in a while we have someone who is not able to connect with a video, and in that case we will do it over audio if we've made every attempt. So that is an option for folks as well.
I think that's so, the beauty about telehealth is that there's a range of methods that one can use, whether that's, messaging, which is some of the evidence I tried to share for other models. There's WhatsApp messaging, there's telephone, there's web-based platforms, and all of that really just puts the information really right at the tip of the hands of the patient. And that is what we want, is that patients would be able to access care if and when needed. And especially, I hope I really brought that point home when you think about services like medication abortion, like HIV, STI, where there are some individual characteristics, or when you think about stigma, when you think about harassment from protesters, that make it just difficult. It's not just the distance, it's not just the childcare, it is the actual environment that will make it difficult for them to access services. Telehealth really, I think, rises to the fore. And if I could just add one more thing, is to say that there's always an opportunity for us to be learning from global settings. We have been talking about telehealth, I feel like, in the last 10 or so years, but quite frankly, this kind of service provision has been happening for much, much longer. And in low resource settings, the use of telephones to provide reminders and other kinds of services for sexual and reproductive health has been happening for a long time. And so there are lessons that we can learn from those settings, but there are also lessons that we can translate to them, particularly as we're thinking about different protocols for, contraceptive care. There just isn't as much available in terms of online platforms in some of these global settings. And certainly also in the case of medication abortion, Leah, I am so grateful to you and your other colleagues who've been really leading the way in terms of the no-touch abortion protocols, which I believe will have great value for low resource settings, where the act of going and getting an ultrasound, the act of doing some of these other things that don't really need to happen are insurmountable barriers for some in those contexts. So I really want to impress on us that it is a sort of a bi-directional space that we're in where telehealth is concerned, where we can learn from some of these global settings that have been largely doing this for a long time, and where we can also send some of our information, whether that's around protocols or, you know, fashioning some of our online platforms to really develop, not to develop, but to deliver services in these settings. So I don't know if there are other questions.
We're seeing across many different disciplines that patients being at home now, clients being at home, has kind of totally flipped the switch, and so many positives, as you both have mentioned, that, you know, seeing family dynamics and getting to know them more personally, also seeing risk factors that you may not have seen, having those protocols in place. For example, if you're a behavioral health provider or any type of provider, really, you know, if there's a domestic violence issue, that there could be those types of things addressed with. But just, I guess what I'm trying to say is there are, as Terry Ann mentioned, there's protocols out there. Please don't recreate the wheel. There's lots and lots of resources out there. So if those little things that might make you a little bit nervous about either seeing patients at home or starting telehealth, please reach out to us, because there's lots and lots of resources out there. So I think everybody would have noticed that I actually allowed I didn't unmute everybody, but now you can unmute yourself and ask a question verbally if you'd like to. There's something else in the chat. Leah, as Matt just kind of shared an experience, absolutely understand the background issue. His wife is an NP who just held a televisit with a patient who could only find the privacy for a call in a porta potty. Yeah, it's people are doing what they need to do to get the visits in. So, and that counts for providers too. Some folks are pulling up to clinics and using or outside of places that have Wi-Fi. Those types of things to access services. So,
and I'll just highlight too that, you know, what I think we've realized to some extent is, especially in sexual reproductive health, how much we do because we need to do it, but it's not necessarily either what the evidence requires or what the patient feels that is needed. And that it's a real shift in the way that we think about the healthcare that we're providing. That, you know, again, I'll take the example as simple as the blood pressure, that like we need to see these numbers in this way and we need to be the one who've done it. And it really puts power back into the hands of the patient to say, like, yeah, I can go find a blood pressure. I can make that happen. I'm worried. I would be just as worried about something bad happening to me. I don't want anything bad happen to me. So I will do what I need to get the information to safely be able to do birth control pills. And similarly with the medication abortion, you know, we've done ultrasounds for decades now, and it's really in most cases for us to say, yep, we know that there's a pregnancy there and this is where it is. Patients know when they're pregnant and they know when they don't want to be pregnant anymore. And it really, in some ways, I feel like in a really positive way, puts that power back in their hands to say, yeah, I missed my period. I'm having symptoms. I've had 3 other pregnancies. I know exactly what it feels like. I know I'm pregnant. So you proving it with your ultrasound doesn't necessarily do me any good. It just makes you feel better. And, you know, and if we can do that in the context still of safety and giving the appropriate precautions to make sure that we aren't potentially missing an ectopic pregnancy or something else, and we can look at the evidence to guide us that indicates that we can do that safely, then I think it just creates a different kind of relationship between provider and patient.
Awesome. Well, thank you both so very much. It looks like we've gotten to all of the questions. We so appreciate all of you participating in today's session, and particularly to Leah and Terry Ann for sharing your time and expertise with us today. Just a very quick reminder, we are really relying on you all to help us continue to improve these sessions moving forward. As mentioned, this is our first virtual conference, but we're in week 3. We're still learning things, but we would so very much appreciate your feedback on this session and how we can continue to improve our virtual conference offerings. So please do take just a quick moment. We kept it short and simple. So with that, I will wish you all a wonderful rest of your day and a great weekend. And again, Terry, Ann, and Leah, thank you so very much.
Thank you. Bye, everyone. Happy
Thank
Friday.
you so much. Bye-bye.
Bye, all.